Welcome to the ACS brief from the Frontline Surgeons' Voices. With me today is Dr. Robert Montgomery. Dr. Montgomery is the chair of the Department of Surgery and director of the NYU Langone Transplant Institute at NYU Langone Health in New York. Welcome, Dr. Montgomery.
Thanks, Stephen. It's nice to be here.
Great to have you with us, Bob. And I want to focus on something today that you can shed some very unique light. Many surgeons have encountered being patients, but not to the degree you were because of what you went through, and in particular in your own specialty. So if we can perhaps ask you to start, at what point did you find out that you would need surgery within your own discipline?
So, I think I had an inkling of this from, very early on when I was an intern at Johns Hopkins, when my brother had a sudden death at age 35. And my father had died from dilated cardiomyopathy when I was in my early teens. And, his disease wasn't thought to be familial, but then, of course, when my brother dropped dead, it became clear that it was a genetic disorder. And some years later, we discovered the actual gene mutation, in our family, and it's a splicing gene that's involved in the assembly of some of the large cardiac-specific proteins. So I found that out early in my training. I actually then was told that I needed to have a defibrillator because I got on a treadmill and had a run of ventricular tachycardia at the peak of my exertion. And so I had like a very early version of an ICD that was invented at Hopkins, and Levi Watkins actually implanted my ICD, and it required abdominal implantation and a thoracotomy back in those days. So it was a big deal. It was, everyone I think thought it was going to be the end of my surgical career. I was in the first 1,000 people to get an ICD and the first practicing surgeon to have one. And they thought that probably the electrocautery, the noise, the electronic noise from the electrocautery would set it off. And so they asked me to start thinking about other medical specialties that I might be interested in at that point. So it was a very devastating moment because all I wanted to do was be a surgeon.
Well, you certainly defied the odds, and then some, being chair of one of the most prestigious surgical departments in the country. So how did the journey go from there to your actually becoming a transplant recipient?
Well, I had some great mentors, as I think many of us do, that believed in me and gave me a chance to prove that I could do this. And John Cameron was certainly that person for me, as well as Levi Watkins. And so I went off actually right after I had the ICD placed to Oxford. I was meant to be there for 2 years, but I extended that time and obtained a DPhil or a PhD in immunology with Sir Peter Morris. And so, then when I came back, believe it or not, we went into, I did well during that time. And we went into the EP lab with all the equipment that you'd have in the operating room and tested the electrocautery, and they put a magnet on my device and listened, and there was no interaction. So John Cameron said, okay, let's see what happens. And I finished my training and, went on from there.
And more recently, you went through some additional experiences, I understand.
Yeah, so actually, kind of spread out over the next 30 years, after I came back from Oxford, I had periods of stability sort of punctuated by near-death experiences, and they were kind of spread out over many years when I would have a cardiac arrest and get defibrillated. So the device saved my life 7 times. But as things progressed and my function started to drop off, I had an experience in 2017 where I was down in Patagonia. I'm an outdoorsman, and developed septic shock from a Pseudomonas pneumonia and then cardiogenic shock, and was in a coma for a month in a little hospital in the middle of nowhere in Patagonia, and had to be finally airlifted back. And then when I woke up, I couldn't talk or walk or eat or drink, and had to go through intensive rehab. And, I somehow shook that off, but then had several other really bad arrests where the defibrillator didn't work, and I had prolonged CPR, and then developed ventricular storm at one point when I was in Italy. Was very lucky to make it back to the US, and then was listed at that point. But it shows how sick that you have to get because of the shortage of organs, just how sick one has to become before you really have the criteria for being listed for a transplant. So it's a pretty extraordinary thing that, I was just very lucky to have made it. But it really pointed out to me, some of the problems with my own specialty in terms of, the tremendous number of people that are lost even before they get put on the list. And then over half of the people who get listed never make it across the finish line.
Thankfully, you did make it across the finish line. And it's interesting to hear you talk about things like CPR, septic shock, coma, rather nonchalantly, the way other people might talk about, what they did on the weekend. It's, I guess, you've been through so much. It's fascinating to hear you describe it. How about the transplant experience itself, being on the patient end of things? We talk about empathy. We talk about trying to understand the patient's viewpoint. What was that like for you, knowing A, what had to happen, all the things that had to come together, and B, what could go sideways, what could go wrong?
Yeah, so, believe it or not, the actual transplant experience, I had my heart transplant in 2018, was the easiest part of the whole thing, because it was everything that led up to that was really terrifying in a way, and and just really close calls. And the transplant itself went very well. I did decide to take a hepatitis-C-positive organ. I did that for a number of reasons. We had just developed a protocol for using the ADDs, drugs for that had such a high rate of eliminating Hep C virus in transplant patients, so that they could receive these organs that were being discarded because of the opiate epidemic there. 25% of the individuals who die of a drug overdose are hepatitis-C positive. That's way more Hep C positive donors than we have recipients, Hep C positive recipients. So we started using these organs in Hep C negative recipients, and then treating them with the direct acting antivirals. And so I was one of those people in the early trial, and it also, I think, alleviated some of my anxiety about actually taking an organ from someone on our list, because I had some guilt about that, I guess. But essentially, I was able to use an organ that probably would have been discarded.
Certainly leading by example, just to say the least. So now when you talk to patients, your patients and patients undergoing transplant, you're talking about Hep C organs from a different light, obviously.
Exactly. It's hard to, when I pitch the idea to my patients and then tell them that I did it, for them to kind of look at me and say, ooh, I don't want to do that, So yeah, I think a lot of my colleagues tell that story too when they talk to patients. So that's helped.
So how have all of these things, I mean, it's starting, I guess, with even your father dying when you're a teen, and your brother in his 30s, and all of your various episodes between open surgery, thorax and abdomen for your defibrillator, and all the things you've been through, and now your transplant. How's your perspective evolved? Your empathy for patients, how have things changed over time for you?
Yeah, I mean, I think, I think an interesting part of this story is that really I've been a patient as long as I've been a doctor. And so those two identities sort of evolved, in parallel. And so it's not like I had like one moment where, I suddenly switched, it's always been present in my life. But, I think I have had that connection with patients right from the beginning, that I felt like I'm not different than they are. I have the same experiences they have, and I have good experiences with doctors and bad experiences. And, those experiences inform how I interact with my patients. And certainly, like when it comes to problems that are associated with transplantation, side effects from drugs and things like that, I can sit down and talk to them as a peer and say, look, this is what my experience has been, and this is what I did, and this is, how I tried to mitigate that problem, and, that might work for you, it might not, but, here's a suggestion. And people actually text me and call me, and, when they have problems, my patients. And I've also taken care of a lot of surgeons too, who have had transplants over the years, and helped them with some of the side effects that might affect their technical abilities and that sort of thing.
So it's kind of a natural for you to be able to empathize with your patients, whether those patients are other surgeons or the vast majority not other surgeons. Have you been able to translate the degree of empathy, which you clearly have, to surgeons who've not had experiences, near-death experiences as patients, and to inculcate in them a sensitivity as to what patients are going through?
I mean, that's a great question. I don't think I've really focused on that. I mean, I've told my story a lot to, my colleagues in transplantation. And I guess the assumption is that, they will sort of better understand what a patient's journey is, because they can immediately connect with me. They've known me their whole career. So I think it's informative, but it's an interesting thought to really focus on, on that aspect of it, which probably, I think it's not something I've really kind of identified as something that, it would be something I would just kind of naturally gravitate towards. So it's a great thought for sure.
Well, I'm glad I could end by giving you some food for thought, and maybe some way that you could help others who've not been through those experiences make the experiences for their patients much more empathetic, much more understanding, and make people feel more comfortable with what's going on. I'm delighted that you're in fine fettle and good health, and look forward to chatting with you in the future about other transplant-related issues other than your own. But congratulations on your successful outcome.
Well, thank you so much, Stephen. It's been a pleasure to talk to you today. It really has.
Thanks for sharing. I know this your reflections are going to be very beneficial for our listeners and viewers.